Hello and welcome everyone. I'm delighted to see you all back for session 5 of our European Climate Resilient Health Systems course today. My name is Kirsten and I'm again saying hi to you from Frankfurt, Germany, where I'm working on climate change, mainly heat protection for the local public health authority. I will quickly run through the logistics of the course again for you, and then I will hand over to Eric, who will introduce our presenters. We have again 3 great speakers lined up for today, and they will talk to us about opportunities and guidance for lowering the carbon footprint of health systems. Just another quick look at the course objectives, but they are probably pretty familiar to you now. As always, all materials will be available to you following the session or may actually already be up. And so this is where we are at the moment, session 5. And please note that we're taking a break next week. There will be no session this coming Tuesday, March 4th. We'll see you again the week after on the 11th of March. As for today's learning objectives, we will learn how to define scope 1 to 3 of greenhouse gas emissions from health systems and analyze the contributions to each. How to describe the theoretical basis of a life cycle analysis, examine current estimates of greenhouse gas emissions from health systems, and how to identify opportunities to reduce emissions within each scope and associated examples. Apologies. Now, before we come to the actual presentations, usual quick bit of housekeeping. Again, the logistics remain the same as before. We will have a 90-minute session, 1 lecture, 2 case studies, followed by the question and answer session. And please make sure you type your questions in the Q&A box, as the chat is way too busy for us to look for questions there. And again, the attendance is also as before, you need to use your personal Zoom link. Otherwise, your attendance will not be recorded. And to get the certificate of participation, you do need to attend at least 70% of all sessions with your personal Zoom link, and you will need to pass the final exam with a score of at least 70%. And once again, stick with the 1 email address, otherwise this won't work. And that is it already. Just a quick note that the exam link will only be made available after the last session, so don't worry about that yet. And with that, I'll hand over to Eric now, who will first introduce himself and then the first speaker. And I wish you all a very enjoyable session today.
Hello, everyone.
Sorry.
Good evening.
No.
Good afternoon and good evening, depending from where you are joining our session. My name is Eric Twomey, and as a fellow in climate and health at ASPHER Brussels in Europe, I will be co-moderating the session together with Kirsten. And to introduce the 3 presenters from today, I will start with the lecturer. This is Dr. Laurie Marrauld. She's a lecturer at the French School of Public Health, specializing in digital health and sustainable care. She leads the RESPECT Research Chair on Healthcare Resilience and spearheads the SHIFT Project's Decarbonization Health Initiative. Her expertise lies in transforming healthcare organizations to adapt to ecological and epidemiological transitions, with focus on sustainability and operational resilience. She also serves as an expert for the French Ministry of Health and Ecological Planning in the healthcare sector and collaborates with Northeastern University in Boston as part of the Harkness Fellowship. So we will start with Laurie. So without any further ado, I will hand over the floor to you, Laurie. Welcome, and the stage is yours.
Thank you very much, Eric. Hello, everyone, and thank you for being here today. So I'm very honored to present this session. I'm going to share my presentation. So does anyone can see the presentation is okay? I'm not sure I can read the chat, so if you can just tell me if it's okay.
Yes, we can see it in the presenting mode. It's all clear.
Okay, that's perfect. So Thank you very much. I'm very honored to present this session on decarbonization of healthcare for a sustainable health system. So today we will discuss the topic of decarbonization, starting with carbon diagnostics in healthcare and the tools that can be used to reduce emissions in healthcare sector. I will also address the strategies that can be implemented both at the level of healthcare facilities and across the entire value chain in healthcare system to achieve net zero emission by 2050. So net zero must remain our objective since decarbonization, while necessary for all industries, is particularly essential for healthcare. Moreover, we will see that it is highly desirable. In one hand, climate change has numerous negative effects on public health, as you all know, and you will see the healthcare system significantly contributes to these harmful health effects, unfortunately. On the other hand, healthcare systems must also withstand the impacts of climate change themselves. And this is not yet guaranteed today. Additionally, strain pressure on certain natural resources may intensify over the 21st century. So while not all resources will be affected, some will, making it absolutely essential to address these issues today to avoid increasing constraints in the future. So this is the agenda for the session. We will talk about, of course, the definition of decarbonization and the emission, what we call emission scopes. So today, carbon measurement in healthcare follows various protocols, including GHG protocol, which is the most widely used worldwide. It defines 3 scopes, and we will talk about this. What does it mean? This 3 scopes. We will try to understand also the life cycle analysis or life cycle assessment. They are meant to serve an action-oriented tool. It's interesting to keep that in mind. It's not just about the diagnosis, it's also about taking action. And much like the carbon footprint assessment, they are not always applied very effectively, especially in healthcare, and we will try to understand why. So after that, we will try to review the current THG emissions. Where are located these emissions today? What are the opportunities for decarbonization in healthcare? And what kind of synergy we can find between health and climate policy? But the other speakers will also address this topic in depth. So let's begin by examining greenhouse gas emissions in healthcare. So currently, healthcare systems worldwide contribute between 4.4% and 5.2% of total THG emissions. But these figures may vary slightly. It depends the reference you use. This means that healthcare generates more emissions than the entire global aviation industry, for example, which account for approximately 2.5%. If the healthcare system were a country, it would be the 5th largest emitter of greenhouse gases, but maybe you already know that. So these emissions come from various sources, and we will see that, including hospital constructions, infrastructures, energy consumption, pharmaceutical production, waste management, transportations of professional and patient, etc. So understanding the entire healthcare value chain is critical, as carbon assessment help identify all processes that sustain healthcare activities. Without a comprehensive understanding of this processes, disruption in critical healthcare services could occur. You can also say that some greenhouse gases contribute more to climate change. Like, for example, medical cases, desflurane has the most potent greenhouse gas effect with a global warming potential of 2,540. That means that 1 kilo of desflurane is the equivalent of 2,540 kilos of CO2, which is huge. So the carbon footprint of healthcare system differs across regions, but emissions are significantly higher in developed countries. So you can see, for example, the United States account for more than 25% of total healthcare emissions. China contributes approximately to 17%, while the European Union represents around 12%. And you have other countries with a large population that don't really contribute so much to healthcare emissions, like India, for example. Hospitals and pharmaceutical products are among the largest contributors to emissions in healthcare system in that sector. So when we talk about Scope 1, Scope 2, Scope 3 of emissions, what do we talk about? So we analyze emission throughout the entire chain value: upstream, direct emissions, and downstream emissions. So these emissions are categorized into 3 scopes. So Scope 1, these are the direct emissions from healthcare facilities and production sites. This includes heating, fossil fuel-powered hospital vehicles, and on-site energy production when you have some on-site energy production. Scope 2 are the indirect emissions for purchased and electricity, cooling, and heating network. And Scope 3 basically is everything else. So indirect emission from the entire value chain, including pharmaceuticals, medical devices, furniture, patient food, professional travel, freight transport, waste management, building depreciation. You can also have investment, but they are not all the time included in the carbon footprint assessment that we usually do. An important point when comparing emission scopes is to understand the orders of magnitude. While Scope 1 and 2, and specifically Scope 1, can see as easy to reduce because maybe it's easy to change the way that you heat your building, maybe it's easy to do some insulation. Scope 3 is from far the most important source of emission, with accounting for over 80% of emission most of the time. And it can be also the hardest part of the decarbonization, because it's not so easy to have access to the emission upstream in the supply chain. So this order of magnitude is very interesting to keep in mind, because most of the time people can tell you we will be net zero, but they talk about Scope 1 and Scope 2. So they will be the net zero on maybe 20% of all emissions. So it depends, of course, sometimes it can be 30, 35, but it's never 100% and from far. And it can be interesting for you to pay attention to that kind of presentation. So among the recent results that are interesting to look at, there is, for example, a study that we carried out with our colleague Baptiste Andrieux and other colleagues in France, which in fact shows the relationship between energy consumed per person in each region for the healthcare facilities, for the healthcare system, and the healthcare access and quality index. And what you can see is there is a relationship between the two, and there is a relationship which is not a proportional line, but rather than an exponential curve. So that means there is a strong, first, there is a strong correlation, of course, between energy supply, energy consumption per person, and the healthcare access and quality index, so in this graph. But that also means there is a kind of a ceiling effect to the increase of energy consumption. So this same ceiling effect is found when we look, for example, at the Human Development Index. And we see that Human Development Index increases with income, but at a certain point, there is a kind of a ceiling effect, as I said, and the Human Development Index will no longer increases with rising income. And it's a bit the same thing with energy, consumption of energy and healthcare system. It is also interesting to compare this with the other graph on the other side, on the right, which comes from other studies. And the more greenhouse gases I consume, the better my index of access and quality index in quality of care index will be, except that there are small differences. You can see, for example, France, as I'm French, I will take the liberty to use that example, is better placed in the graph here, because in fact, it consumes quite a lot of energy, but a large proportion of its electricity is decarbonized, which means that we can have per capita emissions that are lower than they would have been if we hadn't been using decarbonized energy sources. So it's not really a decoupling, energy decoupling. That means you can have economic growth forever and at the same time reducing energy consumption. It's not really decoupling or reducing emissions, but it's very interesting to see that we can make a real difference with decarbonized energy suppliers. Let's talk now about the life cycle analysis, which is a method of assessing environmental impact. So it's not just a carbon assessment, and I'm specialized in decarbonization, but life cycle analysis, life cycle assessment is not just a carbon assessment. It's much an environmental assessment worldwide. So I took the liberty of using this diagram that you can see here because for two reasons. The first is that it actually explains very well what a cradle to grave cycle assessment is. And once you can find it free online, because I found it on Wikipedia. And I like to take the liberty to say that Wikipedia remains a good source of information, even if it's an information that obviously need to be verified. We are lucky enough to have this open source site, and I think it would be interesting to continue to have access to it with, of course, the best possible system of reviewing and verifying information. And second point, we can observe about this life cycle analysis, particularly on the products we look at, whether carbon or environmental, that is a life cycle analysis on something that is not really a life cycle, but much more from cradle to grave. And if we think about what is a life cycle, in real life, in nature, life really goes in cycles. So since at a certain point, we become, again, dust, earth, water, or something else, and we mix with living organisms. In the artifacts that we create today, particularly in medical devices, for example, or building that we build, that we put up, we are more into a linear logic. We are going to take resources that are often limited. We are going to use them for a very short time. If I think about, for example, digital technologies, maybe not for buildings, but for digital technologies, that could be a very short times. And we are going to transform them into waste that we cannot all the time recycle, that we are going to export, and that will generate pollution. So it's not really circular economy, and it's difficult to see the cycle. So when we talk about the cradle to grave life cycle assessment, it's to identify the different stage of production, use, and after that, downstream waste of everything that we produce. and use in the goal to evaluate, to assess the environmental impact of each stages. And so the idea is to see which stages of the cycle we can act on to make these devices more sustainable. And the ideal perception, the ideal goal is to find a way to make it circular, to make it a real cycle. So let's move to another example. I'm not a specialist in life cycle analysis. I'm more a specialist in decarbonization. So I'm not a specialist in pharmaceutical production myself, but I thought it was interesting. It was an interesting example from this article on the production of biodrugs with all the temperature maintenance requirement of bioreactors, which also consume a lot of energy. And it's interesting, actually, because depending on whether you're looking at chemical drugs or biomedicines, you will see that carbon emissions are not exactly at the same stage, at the same place. And so we cannot have a single solution for the whole medicines, for the whole pharmacopoeia, but we can imagine having major drug families with major types of process on which we can make common recommendations, for example. So how does this life cycle analysis work in practice, and what purpose does it serve? So you start from a perimeter, a precise scope with a goal in mind. And it's very important to have a goal in mind. And so that's what also interesting to understand. Even if a method is given, this measurement method is applied for a precise objective. And it's also interesting to discuss with your team, with the people that work with you, the objectives around this life cycle analysis. Because if it's just a life cycle analysis that doesn't enable you to change practices, it's a bit discouraging for your team. So it has to be the first step of a more structured project, a more structured strategy to achieve a satisfactory result and quantified result. In this case, for example, the objective is to reduce carbon emission when there are a lot of work involved in gathering the data, so has to have all the energy and material input. Then there's the assessment of the potential environmental impact of all the energy and material consumed. And after that, you have to think about how do you interpret the result so you can make decisions. And finally, using this life cycle analysis to guide your choices while recognizing, and it's very important for me, and this is also tools, methods. Actually, you have to know that each measurement method is a method that have been chosen because it has a certain amount of advantages, but it's also, each method has also its drawbacks, and you should be aware of that. Carbon measurements, methods, and life cycle analysis are not exact tools. They are also based on calculation hypotheses. And so we are getting closer to the truth every day, but we are not necessarily using something that's precise all the time. And we also need to learn to use these tools for the tremendous possibilities they offer us, while being aware of the fact that each tool and each method can have its limits. For example, it's interesting to use LCA to guide your choices, to make some comparison, for example. So should I use single-use devices or reusable medical devices? I can also compare the effectiveness of certain medical procedures. And it's very interesting to use that tools for that. But if you wait until you have a very, very precise number, until you have the complete very, very precise result, maybe you will never take action, because actually all these methods have a bit of uncertainty, and you have to deal with that uncertainty, and that's should not prevent you from taking action. So now let's take a look at the decarbonization opportunity for the first scope. So the first scope, we are really looking at the buildings and infrastructures, and we're going to look at what type of energy we can use for buildings, for example. So we can move towards renewable energies for heat, cooling, and electricity in hospitals. That's the ideal option, of course. At the very least, we need decarbonized energy, which doesn't necessarily mean renewable energy, because, for example, in France, we have a lot of nuclear plants, which is not renewable, but it's decarbonized. We also need to think about construction and deconstruction. Today, we think a lot about construction, but I have a colleague in Northeastern, Nora, I don't know if you're here today, who is working on the possibility of this deconstructing buildings so that the materials can be reused if it's needed in other purpose, or maybe if the condition, the environment of the healthcare facilities are changing, and you will need to reuse the material in other conditions. So it's very interesting. It's very smart design buildings, and that's a kind of innovation and things we can do for the scope 1. I gave you here the example of the initiative that has introduced electric trucks into its vehicle fleets. So the fleets of the hospitals, for example, they are the scope 1, but all other transportations are the scope 3. They are the scope 1 because they directly depend on hospital. So for scope 2, decarbonization items are the energy we purchase, and for example, everything to do with the purchase of renewable energy. So in France, I remember that we have hospitals that have managed to reduce their carbon footprint simply by switching from a certain electricity supplier to a French electricity supplier that were more decarbonized. So that's one of the possibility we have, and insulation is part also of the opportunities of decarbonization you can have in scope 2. So here I gave you the example of a French Polynesia hospital town that is using a seawater air conditioning that is almost a decarbonized system. So for the scope 3, so the scope 3 covers, as I said, everything else, including decarbonization of supply chain. So you're going to have the big focus on low carbon products, reducing the carbon footprint of drug production plants, for example, and waste management. There also the possibility of encouraging low carbon travel and logistic practices. And here I gave you the example of the SHIP project developed by the United Nations Development Program in Sweden, and Healthcare Without Harm, that have the objective to reduce the impact of the manufacture of disposal, medical product and medicine. With the think tank, the SHIFT project, I work with that think tank in France. We have done a scenario development about decarbonization of the French healthcare system. In that scenario development, we proposed some strategy to reduce emission. So here are a part of the proposition that we've made without, I will talk about medicines and medical disposal after, medical devices after. So everything identified in that slide is already well known now from the literature. It's going to be, for example, vegetalizing food, reducing the consumption of medical gases, improving building insulation, improving waste management. even avoiding waste when it's possible, using maybe perhaps reusable devices, having a mobility plans for the professional, and maybe helping the patient also to have some alternative for their mobility, and encourage decarbonized transportation. And we also have calculated the avoided emissions to reach the Paris Agreement. So for the pharmaceutical industry's emission, we have been working specifically to reduce these emissions. And here again, we have several avenues for decarbonization, including, of course, eco-responsible policies and making sure that the carbon weight of medicines and medical devices counts when you buy some medicines, when you purchase it. We count also on the reduction of the drugs emission factor. That means how we can have industrial innovation that enable us to reduce emissions today. The possibility of relocating some of the most polluting or carbon-intensive production to places where electricity production is decarbonized. So, of course, we know that we will not relocate everything and every industries, but maybe we can, in a hand, relocate some very strategic production, and in the other hand, help the current production sites to decarbonize their production. And the reduction of waste in industry and the reuse of certain components, such as solvents, for example, is also a part of the decarbonization proposition. And there is the involvement of healthcare professionals, which is also very, very important. Those practices can also help steer industry in the right direction. And so for medical devices, as for drug purchases, we could already have very significant reduction of over 65% in emission, bearing in mind that today we even advise industry to target to reduce by 80%, since this is what all the French industry is supposed to be doing today to reach the net zero and the Paris Agreement. So if we look at the initiative that we have, for example, in Europe, that will not be exhaustive, and I'm sorry about that. We don't have time, and unfortunately, I don't even know all the initiatives that are present in Europe and worldwide. But for example, you have the Green Operating Room Network. So the Netherlands, which is trying to accelerate the sustainability of care processes in operating theaters. You also have this Sweden fictional hospital in a city that I can pronounce myself, I'm sorry, which aims to inspire with a set of recommendations for creating the most sustainable hospital in the world. And of course, the NHS commitments, a very concrete commitment with the fact that by April 2027, all suppliers must have publicly published their emission reduction targets and must have aligned them with NHS net zero targets. And by April 2028, the NHS requires the individual carbon footprint of each product to be provided. And so NHS is working on methodology to achieve this target. So beyond Europe, you also have many initiatives. And once again, I will not be exhaustive, and I'm sorry about that. I really don't have time to give you too many examples today, but Kenya has committed itself to carbon neutrality, and Argentina has become the first government in the world to include the reduction of greenhouse gas emission of the healthcare sector in their national determined contribution to the Paris Agreement. So that is a huge step forward, and that's a really interesting example to follow. In the USA, the National Academy of Medicine has proposed action for hospitals and healthcare system to reduce emission. And the Joint Commission recognizes organizations committed to reducing their carbon footprint through a sustainable healthcare certification program. It's still not mandatory to do that, but it's very encouraging, and I hope that will evolve in the right direction. As I'm French, I will give you some news about the French initiative too. In France, a roadmap on the ecological planning for healthcare system was formalized in 2023 with reduction targets in many sectors, including building and energy management, sustainable procurement, medicines and medical devices, waste management, training and research, ecological transformation. And that is a very important point because today we need to have more expertise in the healthcare facilities, in the healthcare sector, in the entire healthcare sector. Sustainability must not be a specialty that is not part of the healthcare, that is not part of the care. That must be part of the work for healthcare professionals. And we need to help them to integrate sustainability in their daily practices. And for that, we need more research and more training. We also have work on sustainable mobilities and goals for that and environmental impact of digital technology. Since a few weeks now, the French government also disclosed a methodology for assessing the carbon footprint of medicine to provide all players in the system enforceable carbon footprint methodology. So decarbonization strategy also have their barriers, and one of the main constraints today is, of course, financial. It's often difficult for hospital or certain infrastructure to invest in this major project. You also have some regulatory constraints. Even if regulatory can help you in a hand, you can also have some difficulties, specifically in healthcare, because that can seem sometimes contradictory to do something sustainable and to do something efficient for the healthcare system. So I don't think it's the case. I don't think it's contradictory, but it's just that we don't have enough time in hospitals or in the healthcare system today to really work on this issue in depth. You may also have limited access to expertise and data transparency of production chain. That makes it difficult to adopt these strategies. And yet these decarbonization strategies are also resilience strategies. When faced with a crisis such as COVID-19, for example, we see that we are all in line with we are not at all in line with environmental approach to health. More and more, we will have more and more crisis and environmental crisis in the future. So if we are not a low carbon system and resilient system, we run the risk of saturating healthcare system and environments at the same time, which will necessarily have very negative effects. So resilience of healthcare facilities is also a very important issue. Today, we're seeing impacts on infrastructure, which means direct impact on buildings, value chain, and so on, and major risk of vulnerability of population, of course. And there is also indirect impacts, and sometimes we don't think about that, but linked, for example, to the demand for healthcare and due to the effect of climate change. So all of this puts pressure on resources and healthcare staff. And so we need to improve resilience and decarbonization using a tool that we have today, which is public policy on health and climate combined, and which mobilizes what we call co-benefits. So I'm not going to dwell on it too much because our colleagues will explain it later. And it was already explained a bit last week. But it's true that today we really need to understand the importance of co-benefits of, for example, reducing air pollution and reducing carbon footprint and improving people mobility. We can do that all at once. And so we absolutely must take the opportunity to do it. So there are strong synergies between these health and climate policies, and we need to promote these holistic approaches simultaneously, not saying we will do one after the other, but really trying to do both at the same time. A bit like decarbonization, we can try to prioritize, of course, some major actions, but ideally we can say to ourselves that there are, in fact, several simultaneous actions that will combine. And there are also objectives that are also sustainable development objectives. And then potentially it could be a source of saving. Despite major investment involved, we still have great potential to reduce waste and the cost associated with poor human environmental health, thanks to the synergies between public health and climate policies. And it is not just a project for healthcare system. This is a real project for the society. And I'm a bit surprised to see that political world isn't taking more notice of this magnificent project for society. This is amazing. Everyone will always need the healthcare system in one way or in another, from primary care to specialty care, even to palliative care. And to achieve this, we need to promote interdisciplinary approaches that bring together health, climate, urban planning, as well as sociology, philosophy, maybe art. So we need to encourage the implementation of green health practices. And we mustn't forget that there are a lot of proposals on the table today, notably from the World Health Organization, for example, which provides guidance on how the healthcare system can reduce its emissions and build resilience. In conclusion, I would say that healthcare systems need to reduce their carbon footprint across all emission scopes, not just the visible ones. Resilience and decarbonization strategies are critical to ensure that healthcare facilities can continue to operate in the face of climate change. Public health and climate policies are really powerful when combined to deliver co-benefits that improve both health and the environment. And we have the opportunity to steer our societies toward a new social project, sustainable health, in the face of climate change and environmental disruption. So it's important to take a very serious look at the essential role played by the healthcare system in our societies today, not only as a provider of care, but also as a social and political project for the 21st century. Thank you for your attention.
Okay, perfect. Thank you very much, Laurie, for this very comprehensive overview on the activities around decarbonization, mitigation, and adaptation in the French context, but also in the European and international context. I think what was extremely striking for me as a former healthcare professional working in the operating theater is that even the gases from anesthesia have such a strong impact as greenhouse gas emissions. I was not aware of that. But yeah, I totally agree. Bringing back the cycle into the different life cycle analysis is definitely a very important endeavor. So we would like to continue now. I'm delighted to introduce the next speaker, presenting our first case study of the day. This will be Dr. Sophie Wang. Dr. Sophie Wang is a health system improvement scientist at the OECD based in Paris, leading research on the health co-benefits of climate mitigation policies. Her work focuses on integrating climate resilience into health systems, ensuring sustainability through data-driven health policy solutions. She also examines the role of the healthcare sector in climate governance at the University of Toronto, applying social network analysis to inform evidence-based strategy for improving healthcare delivery. So without further ado, Dr. Sophie Wang, it is a pleasure, and I will now give you pass the word to you, and yeah, the stage is yours.
Thank you very much. All right. Thank you very much, Eric, for your introduction, and thank you, Laurie, for the insightful presentation on sources of emissions across the healthcare system. So good morning, good afternoon, and good evening, everyone. My name is Sophie, and I'm a health policy researcher at the OECD, as well as a postdoctoral fellow cross-appointed at the University of Toronto. So today, on behalf of the climate health team at the OECD, I am pleased to be here today to speak with you on rethinking healthcare systems so that they are sustainable and capable of addressing the growing impacts of climate change. Before we dive in, I wanted to give a quick note on the OECD. As many of you know, the Organization for Economic Cooperation and Development is an intergovernmental organization composed of 38 countries. At the OECD, we collaborate closely with policymakers, stakeholders, academics, and citizens to establish evidence-based international standards, helping countries build stronger, fairer, and more sustainable societies. We serve as a global platform where governments come together to share experiences and exchange knowledge to co-create solutions to common challenges. Addressing climate change is a cross-cutting priority across the organization, guiding our work across sectors to drive impactful systemic change. And health systems sit at the intersection of this agenda, not only as contributors to greenhouse gas emissions, as we've just heard, but also as critical players in enabling sustainable healthcare systems. So at the OECD, we work with countries to ensure that healthcare systems are both environmentally sustainable and capable of adapting to future climate challenges. So I want to highlight 3 critical takeaways that I hope you will remember after this presentation. First, healthcare systems can deliver high-performing care with lower emissions. We know that health systems can optimize operations, reduce waste, and lower their carbon footprint, all while maintaining or even improving on quality of care. Second, win-win policies can bring both immediate and longer-term impacts or benefits for both healthcare and healthcare quality, as well as lowering carbon emissions. So this is really touching on the co-benefits that Laurie has previously mentioned. And third, everyone in the healthcare systems, from clinicians to administrators, policymakers, researchers, and patients, we all have a role to play in reducing emissions. I'm sure that you are all well aware by now that healthcare systems contribute significantly to global greenhouse gas emissions. Within the OECD, this amounts to approximately 4 to 5% of national greenhouse gas emissions. To put this into context, aviation contributes towards 2.5%. We have just learned from the previous lecture that this 5% of health system contribution to greenhouse gas emission includes things from several different scopes. We learned about scope 1, scope 2, and scope 3. So these may include energy use in hospitals, transportation to patients and staff, as well as procurement of goods and services along the supply chain. So why is this important? This is important because it means that health systems, again, are not just responders to climate threats, but are also well positioned to be part of the solution. So then the question is, what can health systems actors do to reduce these emissions? At the OECD, we developed a framework for targeted strategies to decarbonize the healthcare sector. The framework highlights three main approaches. So starting from the left, we have reducing demand for healthcare through prevention, as well as investments in public health. And secondly, middle, reducing waste and inefficiencies to optimize care delivery. And third, to the right, reducing emissions from existing supply by greening procurement, energy use in hospitals, as well as clinical practices. It's important to note that the first two areas, so reducing demand for care, as well as reducing waste and low-value care, these are two well-established health system priorities to improve efficiency, care quality, and patient safety. So what's new really is the added focus on reducing emissions from existing care as a complementary objective. So this is the right-hand side column. And by acknowledging that existing strategies to improve population health and care quality can also lower carbon emissions, we really create a powerful synergy between health outcomes, cost savings, and climate action. So next, I want to move to this chart, really demonstrating that there are many health systems that are already delivering high-performing care with lower emissions. So what we've done in this chart is that we've plotted all 38 OECD countries by their healthcare emissions as well as avoidable mortality. And in this case, we are using avoidable mortality as an indicator of care quality. And these, along these two axes of carbon emissions from the healthcare sector, as well as avoidable mortality, we are plotting this against the OECD average for all 38 countries. So I want to point your attention to the lower left quadrant. So the dots that are highlighted in green, and notice that nearly half of OECD countries have managed to keep both emissions and avoidable mortality below the OECD average. And the main takeaway that I want you to leave with is that many healthcare systems are already delivering high-performing care and maintaining a lower carbon footprint, really showing us that healthcare quality and sustainability can go hand in hand and is not necessarily a trade-off. Just to point you towards some early insights that we have gained through a policy survey that was sent to countries, really shedding light on some of the factors that may have contributed towards what we're seeing here. So, for example, many countries, or some countries, have already established dedicated climate change and health units within their ministries of health to really coordinate mitigation as well as adaptation efforts. Some countries have introduced sustainability reporting requirements either at the health system level or at the facility level. And then others have also set very concrete sustainability targets for the healthcare sector. I'm sure everyone is aware of NHS's targets. And so these are some steps that appear to be guiding health systems towards lowering emissions while preserving or even improving care quality. Beyond the healthcare sector, there are other areas that also drive substantial emissions. So emissions from food and agriculture represents roughly a third of global carbon emissions or global greenhouse gas emissions, passenger transport around a quarter, and household energy use adds another 10%. And I also just wanted to note that these numbers are representative of OECD countries and may shift a little bit depending on the country context. What is really striking here is that the same systems that are driving these emissions, so namely industrialized food production, car-centric transportation, and fossil fuel reliant energy use are also driving major health risks like unhealthy diets, sedentary behavior, and air pollution. And when considered together, these health risk factors are driving nearly 10% of chronic disease burden across the OECD. So the good news is that existing public health policies are already targeting many of these health risk factors. And by investing in these win-win policies, not only do they deliver on health gain in the near term through reducing exposure to health risks, as we've just seen, but also secure long-term benefits by mitigating climate change and its future health impacts. So in many OECD countries, we are already seeing policies that simultaneously improve public health and reduce emissions. So again, this is what we mean by these win-win policies. And these types of policies, they typically address the three major areas that we've just seen. So really driving healthier and more sustainable diet consumption, really encouraging the use of lower emission transportation options, and reducing fossil fuel-based household energy use. So these policies typically are spread across a continuum of restrictiveness from laws and regulations, as you see on the left-hand side, to information-based and behavioral science-based policies on the right-hand side. And these examples of these policies may include, for example, making fresh produce more affordable or ensuring public procurement processes that health and sustainable food is offered within publicly funded settings, such as hospitals, schools, and prisons. They can, for transportation, they can include policies such as investing in cycling infrastructure or subsidizing public transport. In Germany, for example, you'll know that in 2023, there was and still is a 49 euro public transportation ticket that allows access to public and trains across the country. And for household energy, these can include programs that subsidize energy efficient home renovations, for example, or encouraging the use of renewable energies, such as solar or wind-powered energy to cut household carbon footprints. What's essential here is that these three areas are intimately tied to major health risks. So again, poor diets, sedentary lifestyles, and pollution exposure. And by addressing them with these coherent cross-sector policies, countries can achieve both environmental and health gains together. And that's why we refer to them as win-win policies, as they advance both population health while contributing to climate objectives. So among the different constellations of actors involved in the healthcare systems, everyone has a role to play in improving health system sustainability. For health policymakers, these can include actions to promote public health policies that reduce the longer-term demand for care, embed sustainability criteria into procurement and regulations. Policymakers can also set national or subnational decarbonization targets and embed sustainability reporting requirements within the healthcare system to promote transparency and also foster accountability. Administrators can also play a key role in coordinating care and shaping incentives so that clinicians can avoid low-value care. Administrators can also seek opportunities to invest in energy-efficient hospital infrastructure and transitioning towards renewable energy sources, as well as promote digital tools that leverages the use of telemedicine to really cut down on travel-related emissions. Providers have also a big role to play and can choose, for example, can choose lower emitting clinical products such as inhalers and anesthetics, which we heard earlier, that's driving a substantial portion of health systems contribution as well. Providers can also choose to practice evidence-based care that reduces overtreatment and also work with patients together on shared decision-making and promote preventative care. And lastly, for patients, patients also have a part to play by adopting healthier and more sustainable lifestyles, such as using more active forms of transportation, choosing more balanced diets that really benefits our own health as well as the health of the environment. So before we wrap up, I wanted to circle back to the 3 key messages that I began with earlier. Firstly, that healthcare systems can deliver high-performing care with lower emissions. So really, health systems do not have to choose between quality and sustainability. We have seen that there are existing healthcare systems that are already delivering excellent patient outcomes while cutting carbon footprints. Second, win-win policies benefit both health and the climate. When we shift to a more sustainable model of living, like promoting active transportation, healthier diets, and consume efficient energy use, we see immediate health gains. And over the longer term, we also reap benefits for the healthcare system as well from the reduced climate impact. And lastly, I wanted to stress that everyone has a role, from policymakers setting national goals to administrators investing in green infrastructure, to providers choosing low-emitting clinical products, to patients adopting healthier lifestyles. Each stakeholder can contribute to reducing healthcare emissions while improving care. Thank you very much.
Thanks to you, Sophie, very much for this very insightful overview on the activities of OECD and different OECD countries in this context, and especially for the 3 points that you elaborated. We will now continue with the second case study of today, which will revolve a little bit less on the institution, more on a country-specific topic. To do that, I would like to introduce our third and last speaker, Professor Antoine Flahault. Professor Antoine Flahault is a leading global health expert and director of the Institute of Global Health at the University of Geneva in Switzerland. He has held key leadership roles, including former president of ASPHER and founding director of the French School of Public Health. His research focuses on mathematical modeling of infectious diseases, and he has advised major global health bodies, including WHO Europe and the Swiss COVID-19 Science Task Force. With a strong track record in epidemic surveillance and climate-related health risks, his work bridges public health policy, resilience, and preparedness for climate-driven health challenges. So thank you very much for joining today, Professor Antoine Flahault. The stage is yours.
Thank you very much, Eric, and thank you for your kind words. And hello, everyone. I'm impressed by the attendance and also by the level of participation of all of you at this meeting. I will try to take advantage of both lectures and case we had from Laurie Marrauld from the SHIFT project and from OECD, because you will see that we will try to see in practice how to first assess, and second, how to reduce the carbon footprint in Switzerland, particularly in Geneva. I have no conflict of interest on this matter. I want to show you again this picture from which has been shown by Laurie a couple of minutes ago, just showing you that the reason why we wanted first to try to assess and reduce the food carbon footprint in Geneva was the fact that Switzerland has probably a very high-performing healthcare system, but at a high ecological cost. We are the third most polluting healthcare system in the world per capita. And when we have seen that usually it's about 5% of the national emission in Switzerland, it's 6, maybe 7% of the national emission. So we have, yes, a good healthcare systems in terms of quality, but highly polluting. We have taken, as I said, we have not reinvented the wheel. We have taken the methodology from the SHIFT project, which has been very well presented by Laurie a couple of minutes ago. And so just to tell you, we adopted it and we tried to use it for estimating our footprint emission in our healthcare system in Geneva. The boundaries of our studies was to survey and to interview people who were in charge of the laboratories, of the medical offices, of the pharmacies, of the nursing home, of the ambulances, of the hospitals and clinics, and of the home care institutions. We did not use, for instance, the Ministry of Health itself, because it is embedded with other ministries and it was not easy to disentangle. Our methods were both a bottom-up approach, just by interviewing, by trying to know about the building operations, the heating, electricity, about how the people came to their work, by car, by bicycle, by public transportation, how many professionals were working, what were their purchases in terms of food, of IT, of devices, of medicines, and so on. And also, we had a top-down approach, because when data were not available or not precise enough, we had to extrapolate or sometimes to use some calculation. I will show you the type of calculation we used is when we had these data which were cleaned per kilometer, we were able to introduce an emission factor and to transform that in a greenhouse gas emission equivalent, kilogram equivalent in terms of CO2. The result of our survey is that hospitals, you will not be surprised, are playing a leading role in greenhouse gas emission, and nursing home also, and of course medical offices. What is interesting also to see is how to break down the footprint within the major sector, within the sector of a hospital. And you can see that medicines and medical device, approximately equal part, play also a major role in this greenhouse gas emission. Of course, heating, transport play a role too, but medicines and medical device are the main drivers of these CO2 emissions. And here we included the 3 scopes Laurie mentioned several times in her talk. So maybe the big finding of our survey was to see the enormous carbon footprint of medicine. You know, in fact, medicine is such, and the pharmaceutical industry is such an emitter of carbon footprint that it has a major role, which is probably more than the automotive industry, the industry of cars, of individual cars. We are facing challenges and we are responsible, as it has been said clearly and also by Sophie Wang from OECD. Hospitals have an important responsibility. The medicines and medical device play a prominent role, and we can have some actions in various sectors like buildings, transportation, and food industry. It has been said a couple of times today. And we are facing the challenge of an aging society. Of course, everyone all over the world, and particularly in the Western world, but also in Asia, are facing an aging of the population. So we will need these direct and indirect levers to curb the carbon emission. The direct intervention we will focus on in Geneva are about medicines with, as you mentioned, also the policy drivers, but also labeling towards a more responsible use to look for alternatives when it is possible, the buildings to improve efficiency and decarbonization, the transportation, the food, as it has been said, and particularly by reducing red meat and ultra-processed food in all the healthcare sectors, the anesthetic gases, it has been clearly said, and bronchodilatators too. And the indirect interventions, which were also mentioned particularly by Sophie Wang a couple of minutes ago, is improving efficiency of the healthcare systems. We have mentioned a couple of things. We may also group hospitals like it has been done in Denmark. We may fight against waste in healthcare delivery. And as Sophie mentioned, it's 20% of waste in the healthcare expenditure, which could be saved. Digitalization with the electronic patient record in particular, and prevention and health promotion, exactly what Sophie said. The co-benefits of an active mobility, which is good for health and good for the climate, the healthy diet, which is good for health and also good for the climate, and reducing tobacco and alcohol consumption, which is not enough reminded. We have tried to see a scenario for 2040, and we have seen that just by the regular, I would say, the direct measures, we will not be in position to reduce enough the carbon emission. We need also these measures on medicines and medical devices, and we need to add also the indirect measures, and particularly prevention and promotion and fight against the waste in healthcare systems. So by combining these three domains of reducing carbon footprint, we may come to comply with our commitment regarding the Paris Agreement of the COP21. The limitation of our study is that sometimes we were not able to have direct measurements of the carbon footprint of the healthcare systems in Geneva, and we had to estimate and to use, of course, these estimates from sometimes external extrapolation from external data. So there are some uncertainties on the emission factors for sure, and we have to interpret our results with caution. But if further studies are required for refining our results, you have the general trends and also the scenarios for the future. So my take-home message will be first that we have never conducted such a study in Switzerland, so Geneva Canton, which is approximately 500,000 people in an OECD country, is the first attempt in Switzerland to do that. Second, that solutions does exist to accelerate the transition, and particularly the win-win measures with so many co-benefits, good for the health and good for the aging population to improve the life expectancy without disability. And you know that the most sustainable care is that which does not exist, meaning that if you, through prevention and health promotion, can eliminate, at least reduce the risk of disease, you will reduce the needs of healthcare, and you will reduce also the food carbon emission. I wanted to tell you that we have done that in a group at the Institute of Global Health at the University of Geneva with Bruno Mermillot and Raphaël Tornard, and also with the Climate Accelerator led by Bruno Jorhoum and Nicolas Rey and myself. And it has been published in an open journal, the International Journal of Environmental Research and Public Health, and you can find all these details in this publication. Thank you for your attention.
Thank you very much, Antoine, for this insightful lecture and for disentangling for us the different components within the hospital and healthcare system in the example of Geneva and Switzerland. We now have 14 minutes remaining for question, and we gathered and compiled questions in the background. Unfortunately, the time is not sufficient for them to be asked, all of them, but we will pick up the most interesting, most relevant and pertinent for the context. I will start with a personal question directed maybe to you, Sophie. Please feel free, Antoine and Laurie as well, to answer if you have any knowledge on that. As you have said, Sophie and Antoine underlined this, one major lever to reduce greenhouse gas emissions in the healthcare system is to prevent mortality and morbidity, is to make people not suffer any kind of disease and therefore not needing any healthcare facilities. Do you happen to have any estimations on the quantitative impact that reducing the load of disease could have on greenhouse gas emissions in the next years, while we see a steadily increasing rate of diseases, at least within Europe?
I don't know if Sophie is here. Maybe she's mute. What I cannot answer totally to your question. What we can know is that, for instance, healthy diets can save between 7 and 10 million people from premature deaths, from disabilities, and also physical activities is probably the biggest medicine, the best medication in the world for many diseases. It can double the number of healthy life years. So the objective is not to prolong life with prevention and promotion, because that would tap more on our economies and also on carbon footprint, but it is to improve healthy life years within our life expectancy and compressing morbidity to reduce the time when we need medicines, when we need the healthcare systems, when we need healthcare professionals. So definitely the co-benefits for the climate of many preventive measures are very helpful. But we have to say that it is not true for all preventive measures. Some preventive measures, for instance, screening for breast cancer, is very impactful and important, and it has its cost in terms of carbon footprint. So sometimes we are not in a win-win position, and we need to implement this good policy practice for prevention.
Absolutely. Thank you very much, Antoine. Okay, so there is a second question now coming from Kirsten, I think.
Yeah, it's a question for Laurie. Fikadu was wondering if there is a way we can maintain our levels of energy consumption, healthcare access, care quality, decarbonization, or if there's a trade-off between quality and decarbonization.
Yeah, that is the main question when we talk about decarbonization of healthcare system, and some healthcare professionals could be afraid of the impact of decarbonization of the quality of care. But yes, we will need to think about how we can decarbonize without decreasing the quality of care, and even with improving the quality of care, but we will definitely have to find some trade-offs because the way that we produce today, we produce care, is not necessarily very efficient from an environmental perspective. That means it's not efficient from the human being perspective, because it's, in a way, it's killing us too. So it's short-term versus long-term vision, and we will have to find definitely to find some trade-off, but that means we need to know more about what sustainability means in healthcare system. We need to have more expertise on carbon footprint in the healthcare systems. And for example, yesterday I met a wonderful environmental engineer and physician, so he made the both training, and definitely we need to build bridges between different specialties and to integrate sustainability in the care practices, as I said. So yes, we will have discussions. Some of these discussions will be difficult, but I'm sure we can find great trade-offs, as we find, for example, for health and climate policies. We can find very great trade-off to better access to care and quality of care and environmental sustainability.
Thank you. Eric, do you want to take over?
Yes. Okay. So there's another question directed to you, Antoine, by John Middleton. He's asking, is it possible to have a pharmaceutical industry without a petrochemical industry, or are there any possibilities of substitution?
Yes, thank you for the question. I think the pharmaceutical industry, and particularly pharmaceutical products, is the hidden face of the carbon footprint in our healthcare system, because it's not as visible as heating or as even the food, for instance. So we are using these medicines, and they are producing a lot of greenhouse gas emissions. The reason why is not only because of petrochemistry, is also because of the energy which is used abroad, sometimes in China or in India, which is not decarbonized. In fact, if the energy used for producing these medicines was fully decarbonized, or much better decarbonized, it would improve quickly the carbon footprint of the healthcare systems, which is approximately half of the total carbon emission with the medical device also. So the energy to produce is probably, I don't know, Laurie, if you share with me this assessment, but I would say that the energy which is used for producing this medicine is probably the major driver of the medicine carbon emission.
Yes, absolutely. And transportation is not even the main item that we want to reduce. Actually, it's not. The transportation is very optimized. So today, so it's not necessarily because we want to reduce transportation that we want to change the way we produce healthcare system, or we want to relocate. For example, when we want to relocate, we want to change the way that we produce energy for the pharmaceutical production, mainly.
Thank you for that. As we seem to have lost Sophie, another question for you, Laurie. Ita would like to know if you go back to your slides, if the emissions versus health access and quality graph or plot would have been different if emissions was plotted separately with health access and then later with health quality, instead of using both as in access and quality combined. And the question is asked because access does not necessarily mean quality, or vice versa.
Yes, but indeed, we used that index, access and quality of care index, that is already presented in the literature. So we didn't create this index. So we used it to compare the different healthcare systems, to have a baseline to compare the different healthcare systems. But probably it would be more accurate to separate access of care and quality of care. But you can have an idea of the big picture of the conception of your healthcare system, conception of energy related to access and quality index. So probably that will be better to separate both of them, of the two items. But we already use something that is presented in the literature, so we didn't generate it.
Okay, thank you. So there's another question directed to you again, Antoine, this time from Lutando from South Africa. He thanks you very much for the wonderful presentation, and he asks you, what would low or middle income countries such as South Africa do with financial constraints and limited resources in order to minimize greenhouse gas emissions in healthcare facilities? Is the strategy any different from Europe, or is it similar?
Oh, thank you. It's a great question, and I see also that Sophie came back, so maybe can add to my answer. What I would say to answer to this question, that there is a very excellent work which has been done in the UK at the London School of Hygiene and Tropical Medicine on a case study on Kenya. And the name of the main author is Iris Blom. She was a PhD candidate and she recently passed a PhD in London. And she has produced a couple of papers on Kenya. And Kenya is an interesting country which it's close to South Africa, which is probably much lower income, but which is one of the three most ambitious countries in terms of greenhouse gas emission of its healthcare sector. They want a net zero carbon emission by 2030, so 15 years from now. And this is quite ambitious, and they are facing and struggling between delivering sufficient healthcare and quality healthcare to their population, and also adapting against the consequence of climate change in their country, with flooding, with heat waves and so on, and mosquitoes-borne disease and so on, and also mitigating and trying to mitigate with solar power hospitals, renewable energy, better medicine policies, and so on. So it is something which is achievable. It is something which is reachable. I'm not saying it is an easy goal, particularly for low and middle income countries, but I think it is something which has to be followed carefully. And so I will refer to a couple of papers, even a scoping review of what has been done in the world, particularly in the low and middle income countries, by Iris Blom and collaborators.
Okay, thank you very much, Antoine. And just joined again, Sophie. We lost you there for a second. Maybe the last question of today directed to you. What concrete measures could governments of OECD countries bring up to incentivize private stakeholders within the healthcare system to reduce greenhouse gas emissions?
Thank you very much for the question, and apologies for the technical difficulties earlier. I think within my presentation, we have, within the OECD, mainly worked along the continuums of stakeholders from policymakers, providers, and patients. And in relation to the private sector, so if you're looking to the supply chain, I would think that some policies and strategies that could be embedded would include sustainability criteria that can be put into place to ensure that there are transparent reporting of carbon emissions and the carbon footprint that private industries such as pharmaceuticals, when we think about healthcare systems, are accumulating along their supply chain. So I think that would be one of the things that that could be better implemented.
Okay. Thank you very much, Sophie. Thank you to the three of you speakers, Antoine, Laurie, and Sophie, for joining today and for taking some of your precious time to share your abundant knowledge on the topic. And before closing the session, I would like to remind all participants again, first to please fill out the post survey. That would be highly appreciated, so we know the feedback that you would like to bring. Second, all resources will be on the website where you registered, so you can download all the slide decks, and the session recorded will be on YouTube as well. And third, as mentioned in the beginning, next week we will have a break. There will be no session next week. The next session will be in 2 weeks' time. I would like to thank you all for participating today. I would like to thank GCCHE and ASPHER for bringing up this course. And Kirsten, do you have any closing remarks before closing the call?
Sorry, I can't unmute myself while I'm sharing the screen. Just a big thank you to everyone for joining, and we'll see you all in 2 weeks.
Okay, thank you very much, and have a nice day. Goodbye. Goodbye.